Thank you, Dr. Bharati. Thank you for putting up the course again. We are doing this course third time together, and it's really wonderful to see so many people here. So my job is to talk about femtosecond laser surgery, and before we start, let me tell you, I don't have any financial disclosure. I would like to have some financial disclosure, but I don't have any as of now. Well, the femtosecond laser is an infrared laser which works on the principle of photo disruption. It creates a plasma when in femtosecond laser delivery system. There are two most important things. One is the laser, and second is the optical delivery system or the optical delivery device, which is the glass cone, basically that applanates the cornea. It first flattens the cornea, and then the laser spots, very high energy laser spots in very short duration is delivered to the cornea, which creates plasma. This plasma, like our photo disruption principle, expands, creates a plane of dissection, and later on, when the plasma gets converted into carbon dioxide and water, the carbon dioxide gets absorbed by the endothelium as well as the water. The advantage here is these pulses can be stacked together in different orientation, as in you can put horizontally, vertically, obliquely, many ways. And because of this thing, what we get is a shaped incision. Because of this thing, what we can do is multiple plane incision. Now, when we think about femtosecond laser, we think about LASIK. Well, there are a lot of other things which we can do with femtosecond laser. I'm going to talk about femtosecond laser enabled keratoplasty. Now, as I was telling you that we can put these things together in many shapes, the advantage here would be you can have a graph which is shaped like a head. You can have a graph which is shaped like a mushroom or crisscross pattern, many more patterns. The advantage is very intuitive, very simple. A top head shaped design. Look at this design. The epithelium is smaller, whereas the endothelium is much larger. A condition like pseudophakic corneal edema or a phakic corneal edema, you want more endothelium, but you don't want to take a huge, large graft. Well, this is what is the answer for that. And what about the case like keratoconus, where you have a normal functioning endothelium? You don't want to take a very large graft. You want to take smaller graft, typically 7mm graft. But the suture starts coming into the visual axis, and hence more suture induce astigmatism. But here, what we are doing is a mushroom-shaped graft. Endothelium is taken 7mm only, but the epithelium or the sutures are at almost 8.5 to 9mm zone, which is probably the best for keratoconus or any ectatic corneal disorders. You can also have zigzag shape design, which would give you a very tight seal. All these things, what they do is they ensure that the anterior surface of cornea is uniform, and hence the optical part or the refraction of the cornea is much more regular. You compare it with the penetrating keratoplasty, where the penetrating keratoplasty has vertical wound, which is not very tight. There are reports of wound adhesion after 14 years, 10 years, because the wound is vertical. Because of this thing, the sutures are tighter. Sutures are taken out much later, maybe not before 9 months to 12 months. Whereas, not about this thing, but when we talk about the centration also, or XY centration of graft, we tried all the techniques. We put 8 marker or the RK marker and then do trifrination. Unfortunately, both of them may not correlate together, and you may end up with a decentered graft and finally irregular astigmatism. Whereas in femtosecond enabled keratoplasty, you have best donor to recipient fitting. There is less chance of suture induced astigmatism because your sutures are much more superficial. The edges are interlocking, hence you do not need to put very tight sutures. We handle the tissue very minimally, hence the tissue is much better quality, and hence the final visual outcome is much better. I don't think we'll waste some time on the video. We'll go ahead with the presentation. The suturing technique, as I was telling you, if you are doing a surgery like this, where you're taken a shape of a head-shaped graft or a mushroom-shaped graft, your sutures will only come into the anterior part of the graft, and hence your sutures are much more superficial, and hence sutures are smaller, and they do not induce too much of astigmatism. One of the representative case, uncorrected visual acuity, as you can see, was counting finger because of very advanced keratoconus. Did a femtosecond enabled keratoplasty, and to my surprise, on day 1, the uncorrected vision was 6/9. Well, I would say this is the only surgery which I perform after in terms of corneal transplant, where on day one I'm confident that the vision would be at least 6/12 unaided, and which is a wonderful thing probably. Some results about our mushroom shape femtosecond enable keratoplasty. Well, again, as I told you, most of the time we see that the visual rehabilitation is very fast. Uncorrected visual acuity 6/12 or better on day one, and patient goes back to work within a week time without any doubt. Topographic stabilization, well, most of the time when we do a corneal transplant, we are interested to know whether topographically does it stabilize or not. Same way, in our study we found that from pre-operatively, as you can see in the first time, pre-operative in the first part of the graph, comes down to almost 46, and which maintains it by 1 month time. Hence, the patients are stabilized topographically within a month time, which is a wonderful thing. The refractive stabilization similarly is very predictable, and whatever we are seeing at 1 month stays continuously for forever. Most of us have a problem with intuitive problem rather than problem, perceived problem with femtosecond laser keratoplasty or femtosecond laser, that will it affect endothelium, can it cause some damage to endothelium? Well, no, we did our study and we found out that the endothelium count which came down from pre-operatively to post-op was much more predictable and was similar to any other surgeries what we would perform. We also perform OCT in all our cases to know the graphos apposition and how it behaves compared to the other normal keratoplasty or vertical wound, and we found that the wound was much more stable and the stabilization continued even after removal of sutures. So, to conclude, femtosecond enabled keratoplasty has a multiplanar edge, provides very good sealing, less suture induced astigmatism, and hence the visual rehabilitation is much faster. It's definitely a way to go forward in future, where newer techniques developing based on this platform will give us better and better results in future. Thank you very much.